Dear friends and colleagues, buongiorno. I'm very honored to be here today and to have the opportunity to show you the result of my work and the work of my colleagues. And the best proof of this is the white smile of our patient. B&B company is our reliable partner and friend during last 7 years. We use their production and our patients are happy. In my presentation, I will show you our results, and the main stream is evolution implant. Also, I will speak shortly about history and theory of modern implantation, then about construction of implants, different surgical protocols, and I will show our clinical cases and statistics. Scientific examination of mummies from ancient Egypt proves that dental surgery technique already exists in this ancient world. There were covered shells or polished stones which people tried to use as dental implants, and they put them in fresh sockets. This is iron-made implant which replaced central incisor, and it was found in France. This is a tiny stone from serpentine, and it replaced central incisor in mandible. It was found in Mexico, in Teotihuacan. And this is, everybody knows this picture. There are 3 covered shells implant which replaced 3 teeth. All these artifacts show us that people tried to replace teeth many years ago. And the main is that it was, I show that it was immediate implantation. So after tooth extraction, they put their prefabricated teeth. It's easier to put implant in socket than to drill the bone and then put something there. Let's go to 19th century. This is Italian surgeon Maggiolo, who worked in Paris, and this is the first fundamental work. In this work, we can see the system of implant. It was golden implant made of gold, which also was installed into a fresh socket. And the upper part was screwed with a special screw. After this work, we also can find a lot of different construction: greenfield implant, Leger implant, Adams implant, stroke Vitellium implant. And only in 1952, when Brånemark discovered the phenomenon of osseointegration, started the era of modern implantation. Brånemark's implant was screw form, and but it was 2-stage, because Brånemark observed osseointegration, and the first implantation was conducted by 2-stage. And it also had the crown which screwed and fixed to the bone part. But modern implantation have much more possibilities. We have a lot of different protocols, and because of that, today we will speak about evolution implant, which give us these opportunities. So, first of all, it has active thread, platform offset or platform switching, high mechanical stability in bone, and high mechanical stability under dynamic load. Tightness of abutment to implant, do a 5-degree connexa connection, and uniform occlusion load transfer to bone, and convenience in operation. Connexa connection interface is a conditional detachable connection. So after you tighten the fixing screw, the surface of abutment tangent to taper of abutment, and they wedge together. From clinical point of view, this property is very useful. So this construction stable. The bacteria which can be in the inner part of implant or outside, they never go through or never go in or out. And this microphotograph demonstrates the virtually indistinguishable boundary between two parts, abutment and implant. And if we will look at cylindrical connection, there is a gap between abutment and implant, and this is a place for bacterial contamination and risk of infection periimplantitis. To prove the mechanical stability and dynamic load endurance of the connection, we did finite element analysis. So this 3D construction, vertical construction, we tightened the fixing screw and put dynamic load. This blue color is the surface connection, and it doesn't open. Instead of this, in cylindrical connection in the edge, we see different colors. It demonstrates us the opening of the gap. And in this picture, in this graphic, we see that the gap can reach up to 2.5 millimeters. So when under dynamic load, this gap open and close, and it leads to losing fixation of abutment and of the crown in several years. But connection stays stable, and you don't worry about the loss of stability even in temporal or in final construction. Now let's talk about surgical protocols. As I said, this aggressive screw is very good for primer stability, but to obtain good osseointegration, it's necessary that all the surface of the implant was connected with bone. And this will be the condition for osseointegration and for long-term stability. For this purpose, we use bone expanders or bone condensers. These instruments are very useful when we have bone 3 or 4 types, because this is so-called soft bone, and it contains from spongiosa. Usually, the first drilling helps us to set the direction of the implant, and after that, we use condensers and at the end install the implant. It's very convenient for expanders to work with manual key, which help you to control the direction of implant socket formation, and also you use this stopper, which prevent damage of sinus membrane and correctly make the length of implant socket. So you screw it, and the bone expands and becomes more dense. When you're working with manual key, it's necessary to apply, to lay on a palatal plate. This will prevent the break of vestibular plate. But there are some cases, especially in the lateral aspect of maxilla, when you cannot work with the manual key and you cannot control the position of expanders. In this situation, it's usually after sinus lifting and 3D reconstruction, as we see here. This is CT before and after, in the area of first and second molar. In this situation, we use drills. You see, this is a red drill, 3 millimeters in diameter. And after that, you take implant on machine handpiece and screw it. In this situation, implant work as expander, so it compress and expand the bone. And we obtain very good primer stability So this is X-ray after implantation, and this is final construction. And the third protocol for evolution implant installation is 1 and 2 bone types, so dense bone with a good cortical layer. In this situation, we use all the drills, and at the end we also use cortical drill. This helps us to prevent compression of bone around the neck of the implant and prevent resorption. This is case, a clinical case. See the mandible with good cortical bone. This is drilling with yellow drill, then red, green and pink, and this is cortical and installation of implant. And the final result on X-ray and final overdenture. To prove this property of evolution implant, so the ability to compress the bone, we did experiment on ships. We installed evolution implant using that protocols that I told you about, and in different times, 2 weeks, 4 weeks and 3 months, we investigate the bone around the implant. This is micro CT observation. This yellow color is dense bone around the implant in 2 weeks. 2 weeks more, 4 weeks, we see that this layer is a little bit thinner, but it remains. So we see that it goes the remodeling of bone around implants. And to save this density about implant, it's necessary to make functional loading, because only loading preserve osteointegrated implants and good bone contact. And the main field of application for evolution implants are direct implantation and loading. And again, we proceed mathematical modeling. So this is finite element analysis of 2 implants, evolution implants and cylindrical implants, 4 millimeters in diameter and 10 millimeters long. You see that bone volume contact of evolution implant is more than 34%, 240 square millimeters, and this implant only 158 millimeters. And under axial loading, the axial displacement is less on 21%, 1.5 millimeters. And usual common cylindrical implant, even with micro screw, move more, 1.9 micrometers. And the equivalent stress by mesis also less around evolution implant. So this is a clinical case. Chronic periodontitis, root decay, so tooth are removed. This is, of course, flapless removal and very automatic removal. We cut these roots and then extract them. You see, this is roots. Then we make a very gentle but accurate curettage and prepare the socket and install implant. This is 4.5 millimeters and 14 millimeters long. And in the socket of first molar, we installed implant 5 millimeters in diameter and 12 millimeters long. You see these gaps between implants. To close them, we usually use autogenous bone. Here, between 2 implants, there is a lot of available bone. You harvest it and put around the implants. This is direct temporal ridge modeling. After tightening the screws, we put tissue-supported sling suitures. They help gingiva to fix around these crowns, and you see we form the papillas. This is OPG post-operation. This is emergency profile after 4 months of integration. And this is all ceramic crowns on dental implants. OPG 5 years after, and the crowns. On CT scan, we see the stable bone contact around the implant. And this case is two-stage implantation. So we installed in fully edential maxilla and mandible 6 implants. This is screw-retained restoration, and OPG 3 years post-operation. And here is the criteria for successful immediate implantation and immediate loading. First of all, as we mentioned earlier, this is flapless surgery and very accurate and mini-invasive removal of tooth. You can do like this, so no flap. For extraction, you can use forceps if it's possible to fix the root, but if you have such opportunity, you cut the root and use small periostomes or elevators. Then curettage to remove inflammation tissues. Then we prepare implant socket using one drill and then osteoexpanders. The implant is installed with in contact with palatal bone, and this gap is filled with bone which we can get from a mandible using bone scraper, or you can take a bone in the form of shield in the maxilla and put it here in maxilla tuber. One of the main conditions if you make a big restoration on immediately placed implants is a rigid frame for temporal prosthetics. It's very necessary to obtain instability of every implant. For this purpose, we usually use titanium bar or titanium chain, and on this rigid bar we make restoration. And one more very important thing is adequate antibiotics therapy. We start to use antibiotics before operation and continue 7 days after surgery. Another advantage of evolution implants is the availability of short implant, 6.5 millimeters long. And again, we proceeded to mathematical modeling. This is equivalent stress by mesis around implant, and this is compression under axial loading. These gray areas show us how bone compress with implant under loading. This is model of one implant in soft bone. But if we connect 2 implants, the compression is less and equivalent stress also reduced. So it's better to use these implants together with 2 implants or more. And this clinical case shows us the 5-year result after treatment. See, on the left side there are 2 short implants, and this is 2 common 10 millimeters implant, and the result is the same after 5 years. This is intraoral view. And so in the end of my presentation, I would like to show you some statistics. This is total statistics. So we performed 978 surgeries, 2,467 implants were installed, and we lost 39 implants. Success rate was 98.41%. It's approximately the similar success rate as we can find in literature reviews for other implants. Two-stage success rate is also high. So we proceed two-stage after sinus lifting, after bone reconstruction, or after tooth extraction if we don't make a crown. Here, the same situation, our result and literature review. No, sorry, this is about short implants. Short implants, I don't have too many short implants. The amount is 65, and the success rate is 93. So we lost 4 implants. And this is for immediate loading. The result is approximately the same as two-stage implantation, and the same as we can find in literature. And one interesting thing is the rate of the resorption about implants. When we install implant with immediate loading, the cumulative resorption after 5 years is 0.5, and in two-stage it is 0.8. This is very interesting, and this confirms that immediate loading supports bone and support the level not only of bone but also soft tissue around the implant. And in the end of my presentation, I would like to say thank you for my colleagues doctors. We work together in different clinics and in different cities. And Professor Muraev Aleksander, we have mutual collaboration in scientific research. Thank you all.
Thank you, Doctor, for your presentation.
Thank you.
As I mentioned, I am lucky to see the presentations beforehand, and I've been impressed by many points. So thank you very much.
Thank you.
Thank you.